take you through some examples. Now, we all know that amniotic membrane has certain properties which are actually desirable when we are using amniotic membrane for various disorders. The anti-scarring, anti-angiogenic, and anti-inflammatory properties. They basically allow, if there is any normal tissue which is available, to repopulate the injured site before inflammation and scarring takes over. So basically what it allows is regeneration rather than repair. Now when we use amniotic membrane, there are various principles, and of course these principles, it's sort of a mix and match situation by the way we use it. It can be used just as a patch. The patch could be just a temporary patch, or sometimes we use it as a substitute of the stroma, and then we allow the epithelium to grow over it. And amniotic membrane, of course, is used for limbal stem cell cultivation in the labs as well. Now, when we talk about different conjunctival diseases where amniotic membrane has a role, the most common of which in everybody's practice is a pterygium surgery, where sometimes when we are dealing with recurrent pterygiums, we take the help of amniotic membrane besides probably conjunctival autograft. Now, for example, in this patient, I did not take an autograft, but I just used the amniotic membrane and pulled the conjunctiva over it, and it actually worked pretty well. Now, when we talk about the corneal diseases and use of amniotic membrane in corneal diseases, then sometimes in cases of partial stem cell deficiency, we can actually use just amniotic membrane and see the response, because a lot of time when we reduce the surface inflammation, remove the pannus from the surface and put the amniotic membrane, then the remaining stem cells actually take over, and we actually don't need to do a limbal stem cell transplantation in some of these cases. Now, I'll just take you through some interesting examples, because this is a topic, as I said, is something that everybody has been doing for a very, very long time. This was a patient of fungal keratitis and also had ocular rosacea. Now, it is a challenging situation when you're dealing with fungal keratitis in patients who also has ocular surface inflammation due to various causes. Now, obviously, we could not use steroids. The patient, because of fungal keratitis, developed continued thinning. So we resorted to amniotic membrane transplantation again as a patch and continued with antifungals, and patient responded beautifully and healed with a small scar. This was another interesting patient who presented to us. He was on antivirals for more than 2 months, both oral as well as topical. When we looked at the surface was very dry, there were a lot of mucus, and there was a little shortening of the fornix, and the clinical evaluation gave us a suspicion of more of SJS-like picture. We took a detailed history and we found that patient actually is an HIV positive patient who was on nevirapine earlier and had developed a reaction to nevirapine, which was later discontinued by his treating physician. So basically, patient had developed an ocular SJS, which had led to this kind of persistent defects. So we performed amniotic membrane again as a patch, and within few weeks the patient healed completely. This was another patient of SJS who developed an E. coli keratitis, and in spite of all the efforts, the patient did not respond and again developed thinning. So we used amniotic membrane both as a filling, where we used the glue, because I did not want to remove the surface epithelium from the cornea. The second amniotic membrane, I used sutures, and again the surface healed. This was a patient of chemical burns who presented to us 3 months after the chemical burns with a persistent defect, which even after our treatment did not respond, and this was the stage where finally we decided to do an amniotic membrane again as a patch, and surface finally stabilized. This was a patient where we had done a penetrating keratoplasty. After a few months, he presented with a melt, which initially was a very small melt, but progressed circumferentially. Probably was a combination of tight sutures and other factors. We tried anticoagulanolytic and mild steroids, lubricants, nothing worked. Did amniotic membrane transplantation, and the surface finally healed. Now, we all deal with the burns. Now, burns is actually one of the most common indications where we use amniotic membrane. But one of the things that we need to remember is that amniotic membrane is great for initial stabilization and reducing the inflammation of the surface, but it's not the be-all and end-all of managing these patients of acute chemical burns. Now, there have been numerous studies which have shown that amniotic membrane traps and induces apoptosis of inflammatory cells, and that is how it stabilizes the surface in cases of acute chemical burns. And also when we have to remove these pockets of lime or whatever where we have to excise the conjunctiva, amniotic membrane works beautifully and reduces the chances of similar front formation. we actually performed a study. It was part of my thesis long time ago, and we analyzed that in what all cases and how useful is amniotic membrane in these cases. And what we found was that for mild to moderate cases it works and by itself sufficient to stabilize the ocular surface. But more than moderate to severe cases, it just is an initial adjunct to future therapies, which can be in the form of limbal stem cell transplantation and other things. Naturally, when we deal with patients like this who have grade 4 chemical burns, in those cases amniotic membrane once or twice or whatever number of times we do the amniotic membrane can only make the surface from further melting, but it still does lead to limbal stem cell deficiency and conjunctivalization and require future surgeries. Now this was another interesting patient who was a case of BKC, developed a shield ulcer, and when we removed this plaque and sent it for microbiology, we found that patient had actually fungus. Now again, it was sort of a situation where you cannot give steroids to patients of a BKC with shield ulcer, and patient requires anti-inflammatory treatment. So after initial treatment, when patient did not respond, we did an amniotic membrane transplantation with antifungals and patient responded. And in spite of this big scar in the center, patient actually had a best corrected vision of 6/9. Conjunctivochalasis is a very common and very under-recognized entity, but some of these patients get really miserable because of the severe laxity of the conjunctiva and interference in their day-to-day activities like reading, etc. And these are the patients where we can selectively use, after the excision of this loose conjunctiva amniotic membrane, to stabilize the surface and improve the tear film of the patient. And so as in cases of SLK which do not respond to medical management, we can do an excision of the conjunctiva and put the amniotic membrane to stabilize the surface. However, again, amniotic membrane is not the end-all and be-all of all kind of ocular surface disorders. This patient was a case of aplastic anemia who presented to us with large scleral necrosis. Now, when you have such large scleral defects, then amniotic membrane by itself is not useful, such as cases like this, a necrotizing scleritis in a rheumatoid arthritis, or a patient who actually presented with a large scleral defect with almost the half of eye prolapsing out of that defect. In such cases, amniotic membrane by itself does not have enough structural rigidity to give support, or a patient of surgically induced necrotizing scleritis post-pterygium surgery, where we had to do a scleral patch graft along with an amniotic membrane transplantation. Also, sometimes when we deal with alkali burns, where even though there is a grade 4 burn, but there is also some amount of ocular penetration, and in spite of whatever number of amniotic membrane transplantations we do, the patient's eye do turn tricycle in some cases. So I would conclude, amniotic membrane is extremely helpful tool in ocular surface surgery and has shown to prevent and reduce potentially disastrous damages to the surface. However, we need to remember its limitations while managing the ocular surface disorders. Thank you.